This is the Authority Company Podcast, conversations with leaders that are designing our future. Hola, I'm Joe Pardavila. And do you remember that old episode of Seinfeld when Elaine was labeled a difficult patient and she had trouble accessing her medical records? Well, those days are long gone after the healthcare industry switched to a more user-friendly digital healthcare record where patients and doctors can both access that information. But things have gotten a little more complicated in terms of technology in healthcare. Well, my guest today is Scherpbier. He's the author of the new book, Unvendor, Innovative Healthcare with a Diverse IT Stack. Dr. Scherpbier is a physician and leading expert in IT, and you're about to find out how his methodology and his book can revolutionize healthcare technology. Dr. Scherpbier, welcome to the podcast. How are you?
Good, Joe. Thank you for having me today.
You're very welcome. So I want to start our conversation by talking about the intersection of technology and medicine, because for a lot of folks, I feel like medicine is sort of taking on the mantle of climate change, where we're like, all right, we're not going to fix it with the way we're doing things. Technology is going to have to get ourselves out of this mess. And I feel like that's happening in your world of information technology behind the scenes, because for folks not familiar, and you know this, Doc, it's a mess back there. Like if you looked under the hood in terms of how all these technologies work behind the scenes and the EHRs and the interoperability of them all, it's not pretty. So tell me, will you guys be able to figure this out and have technology lead the way in the future?
Yeah. Well, I actually am a huge fan of health tech and health technology. We only have to go back 15 years when a lot of healthcare was still practiced on paper. I'm talking about the shift from paper medical records to electronic medical records. That happened about 15 years ago. It happened because of the high-tech program, which really gave hospitals and practices incentive monies to switch from their paper record into electronic record. That has made a huge difference. Not everybody likes it. Not everybody agreed with it, but let's think about it. Before that, there was one paper chart. It was often handwritten. Only one person could use it. It was hugely inefficient. So now that almost all practices and all hospitals have their clinical data, medical data electronic, it enables us to do so many more things. First of all, I think top of the list for me, patients have electronic access to their data. That used to be impossible. You could never see into your chart. Now, almost every patient can just look in their chart electronically. That is enormous. That is, I think, the biggest revolution in going from paper to electronic. The patients have direct access to their medical data through their EHR. Physicians and nurses and other clinicians working electronically. That was difficult, and it still is difficult, and it still causes friction, but it is much better than being on paper. Multiple people can work on the chart together. We can automate workflows and mechanisms. So I think the fact that we are on electronic charts with health technology is a huge improvement. Now, I would like to use that as the starting point for the next revolution, right? So where do we go next? And many of those are in my book to talk about what should be the next steps we build on top of this electronic medical record platform.
Awesome. That's great. And one last thing about EHR, which I'm sure we'll probably dig into it later, but the fact is, and I mentioned interoperability, as you know, the idea of the EHR, great idea. And you mentioned the benefits of it. The bad part of it is all these fragmented systems that don't communicate with each other. So I do know there is one main EHR company that handles most hospitals and health systems, but there are some that are different. So sometimes one doesn't interact with the other, and you can't. It's almost like going from Mac to PC. There's some sort of there are some pain points there. Is that improving because that's the one main complaint for the first 15 years of the AHR was the interoperability. Is that gotten better? Are we perfecting that way of communication?
Well, I think it's a good point to point this out. There are 3 large EHR companies in the US, and of course, outside the US, there are others. But in the US, we have 3, each focusing on a special sector in the market. That's mostly on the hospital side. On the ambulatory side, practices, there are at least 100 different EMR companies. At least 100. Some of them you've never heard of. They tend to focus on specific sectors like dermatology or ophthalmology, and there are many, many of them. And so interoperability it's not as easy as it should be. There are standards on how data should flow from one system to another. Those standards are supported by all EHR companies, supposedly. And we should say, let's assume they do. Let's assume all EHR companies have these standards in place. It is still somewhat difficult. And what I feel that as a industry today, and part of my book is an appeal to my peers to say those interoperability tools, they exist today. They're built into your EHR. Start using them. Because if you don't use them, we will never reach the level where interoperability will truly work. I think people are still very much locked into their single vendor and don't often use these interoperability methods. And I know they're difficult. So one of the lines I use a lot is invest in interoperability. And that means invest people in your interoperability team, invest in the skill set of interoperability, and start using interoperability tools so that we can actually make progress there and create a world where we can have multiple systems working together, sharing data. I think you're right to point out it's a weakness. I think it's up to the industry, the health industry, to start improving it themselves and go and say, all right, we've worked hard to put these standards in place. We have one of the standards is FHIR, Fast Health Interoperability Resources, is a standard for interoperability. We need to start using it much more so it becomes common practice in organizations to do this.
Does it become sort of an old dog, new tricks, and then you keep asking the dog to do new tricks? Because you talk about, you did a great job of setting this up. 15 years ago, this did not exist. It was paper records. It was arcane. It was really hard to get information. And so the folks in healthcare, they adapted. So, okay, cool. We're going to go to this electronic method. And then all of a sudden you add and pile on these different either whether it's project management softwares or just softwares in general. Is it just been too much to ask of folks in the industry? Is that part of the reason why we're having this interoperability issue?
The large vendors in this industry have done a good job saying, work with us, we will be your single provider. And there's a good reason to do this. It's of course much easier for a health system to deal with one vendor only, especially if that vendor is a high-performing, solid, some of these are very big companies. Not all of them, but these are very big, hardworking companies. I think, though, we've reached a point, and I think this is a bit of an arc. We've reached a point that innovation right now is going so fast with AI, with other tools, which we'll talk about later, that your single vendor cannot possibly give you the best and most recent on all these fields together. And that's, I think, where we're at a point today that the only way to move ahead is to start incorporating outside technologies that you wouldn't have today. And I think that's mostly because of the rapid innovation that we see today, and relying on the single vendor will take too long and will not allow us to be flexible, innovative, and competitive. And that's why I think this is the time to invest in interoperability so that you can actually go out and incorporate third-party technologies into your health IT stack.
Now, and that sort of brings us to the essence of the book, the unvendor, the idea of not being a single vendor reliant, having these multiple kind of players involved.
Yes.
Now, as an outsider, Doc, I'm not in the healthcare system. To me, and maybe this could be the problem that you're trying to face, is like, man, that single vendor thing sounds a whole lot easier than having to deal with multiple people. So what's the argument to sort of diversify your tech stack?
Yes. No, I think that is exactly right. And I realize very well that there are good reasons that we are in this single vendor world and single vendor mindset. There are really good reasons for that. We didn't get there just by nothing. That is interoperability, it's contracting, it's pricing, it's all of the above. That it's much easier for a health system to manage one coherent, consistent system than to manage multiple connections. We were, by the way, in that phase many, many years ago, I would say in the 1980s, where the philosophy was best of breed. Best of breed means I buy the best lab system and the best radiology system and the best medical record and tie them all together. That has been replaced by the current single vendor methodologies for good reasons, for good business and financial reasons. Where I feel today is that with innovation, going fast and new technologies moving fast, and also the business of healthcare changing fast. That we should talk about this. The business of healthcare is changing. That the existing IT systems limit us in how we can move forward. And that's why I think we ought to shift that balance back to start incorporating more new technologies on top of the platform. So where that takes us, that we will still have our single vendor as our core technology inside our health system. I'm not challenging that at all. That is an important building block on the inside, but it's not the only thing we have. So we start extending and expanding that by adding third-party technologies strategically to fix the problems we have. So I have multiple examples in my book where I think it's appropriate, and some of those are well accepted. For let me give you one example. Ambient clinical documentation is a fairly recent phenomenon where a microphone listens to the patient-doctor conversation, just like we're having a conversation here, and at the end of the encounter, produces a very concise visit summary, a note. The way doctors used to dictate them personally, now it is generated by an AI tool. That is amazing technology, and that is clearly something that most health systems should incorporate, that from a third party on top of their EHR. And most EHRs support that. So I think it's a great example of, okay, this is what we need to be doing. We need to be incorporating this technology rather than building each EHR vendor building their own version of this thing. Include multiples. And I'm saying you might not even include one single one. You might include multiple versions, multiple flavors, each with their own specific strengths. There used to be one or two large vendors, companies doing this ambient clinical documentation. Now there are 50. At the recent HIMSS conference, there were 50 companies doing this. Now, I'm not saying that all of those 50 are excellent, but it's beyond the two. So I think health systems now have an opportunity to say, all right, we have multiple players in this field with different technologies and different price points. It probably brings the price way down. So let's use that as an example to bring multiple tools in. And that's only one example. There will be more where you need to step out of the envelope of your single vendor and bring in additional health tech.
Yeah, and that's a great example. The ambient technology is, I believe, going to be a game changer in your industry.
Absolutely.
Because it's not only going to improve the business side of things, which is, I think, the general part of this conversation today, but the personal part of it.
Yes.
The fact that doctors will now be able to, crazy idea, doc, to be able to look at their patient while they're speaking to them, as opposed to seeing their profile as they're typing in and looking at a screen. So that is going to change the way we do medicine. And like you said, this is and I think you picked the perfect example of adding on your stack, because a lot of these other companies, like you're mentioning, don't have the ability to update and scale up to be able to create that technology. Because one thing you didn't mention there, Doc, is the fact that, yes, it's going to document it, but then at the end of it, it's also going to encapsulate that in text form, where for generations to come, the doctor will be able to look back and say, like, oh, April 14th, this is the complete recap in perfect English. It's not in the old chicken scratch that the doctors have to read from. So it's an incredible technology that is a perfect example of the way you discuss in terms of unvendoring.
Three key benefits of this technology, and I think this is now gaining traction fast. It's better for the physician because I don't need to take time to do my notes after hours.
Yeah.
It's better for the patient because they are speaking to the doctor. What also is turning out is that because of this technology, doctors have very, very quickly learned that in order for your note to be complete, I need to say everything out loud that I want in my note. It's obvious, right? As long as I want to make sure that the patient's medications and clear follow-up steps are in my note. Therefore, I'm going to say them to my patient. So it really improves the quality of the discussion between the patient and doctor. And lastly, research shows that about 50% of the time a doctor is in their electronic health record. 50% of their time, of their day. 50.
Wow.
And most of that is documentation. So that is hugely inefficient. This technology allows us to give that time back to the clinician and make it much more efficient. So better for doctors, better for patients, better for overall team efficiency. That's an obvious win. So that's one example. And that's, I feel, where we need to start looking at our EMR as a core platform where we start adding new technologies, different technologies, and sometimes changing technologies on top of that.
Good stuff. Good stuff. And just out of curiosity, do you have a personal anecdote to share in terms of how you got here? I don't think you woke up one day and unvendor. Like it's not something that came to your dreams. Like, was there what led you to this point to sort of be the apostle in terms of sharing the importance of being sort of multifaceted in your tech stack?
Well, it's a good question, Joe. And I'll be honest, I was a health system chief medical information officer, and I used to convey this single vendor message. Part of my work was to say, let's all be on the same platform because it's better for our teamwork. It's better for our efficiency. So I used to speak the single vendor language myself. And there came a point where I thought, I understand why, because I used to deliver that speech to my doctors. This is why we're doing this. But there comes a point where you see this becomes too limiting and too restrictive. And the four main reasons are innovation. It limits innovation. You have to wait until your vendor finally catches up with this function. And I think the key point there was I worked for several population health companies. Population health, meaning or value-based care, let's call it that, as a different payment model for healthcare, which is really taking on a lot of traction in the world right now. Value-based care is a different way to run a practice or to run a health system. In the old world, if a patient made an appointment, I would see the patient. Under a value-based care project, if a patient makes an appointment, I see the patient, but I am also contracted to care for 1,000 or 2,000 or 10,000 patients who are allocated to my practice, whose care I'm responsible for. If they have chronic conditions, I need to manage them. If they go to the emergency room too often, it's my problem. I need to try to avoid that. So that requires a different way to run my practice. It also requires different software. And that was one of the key points where I felt, in order to do this, we need to move faster. We cannot wait for our electronic health record to catch up, to allow me to not only manage the patient who I'm seeing here today, but also to administer and monitor my panel of patients who I'm responsible for. So population health, I think, was a key moment where I thought we need to become smarter and faster in adopting new technologies so that we can stay competitive. So it's innovation, changing business model. It's also user experience, like we just talked about. If you speak to any doctor in a health system with one of these large vendors, ask them, how's it going? You often get a groan, like, oh. It's just too easy to get that feedback. And I feel if a hospital spends millions, many millions on a health system, and their primary users go, that's not right. That is not right. And there too, I feel we have to move forward and making it better for the users, for the end users, and create a better user experience. So innovation, user experience, keeping up with new business practices, and finally, the cost of health IT. Health IT with these large vendors is extremely expensive. I think by bringing in additional technologies and allowing us to diversify the IT stack, we should be able to bring down the overall cost of health IT.
Nice. And that leads us to something in the book you talk about, all-in pricing, the all-in pricing trap.
Yes. Yes.
Talk about that a little bit and how we can sort of get away from this mega vendor and all, it's something, it's like everything in the world now, we're all about the bundle. Doc, I'm sure you're familiar. Let's bundle everything together. But tell me more about all-in pricing trap.
It is exactly what you're saying. It's bundling, and it makes a lot of sense from a business perspective. And initially, it looks really attractive. Single priced, I buy everything. I'm taken care of. I don't need to, send out a separate RFP. I got everything. That is super attractive, which is one of the drivers that we got to this single vendor point because of this all-in pricing. Once I have all-in pricing, it's highly unlikely that I go somewhere else to buy a different module, right? It's included. Why would I buy it somewhere else? So it starts out as a convenience, but I think then it becomes a trap. Then it becomes a mechanism by which I am so beholden to my vendor that I cannot go outside anymore. And I think that is something we ought to be challenging. These prices are high. You've seen the numbers in my book. The price of health IT for a large organization is extremely high, millions, sometimes billions, for health IT. And these are healthcare organizations. These are supposed to provide healthcare to their patient base, and they're spending a lot of money on IT. So I believe one of the things we should be working toward is breaking through that single price model and cracking that nut. I think so. One example. If I would be able to carve out the revenue cycle portion of a hospital, billing, accounting, which is part of the EHR and a big part of it and a very fundamental part. A hospital
As a
must
big
get
driver
paid.
for it.
Must get paid. You don't. It's like the third rail. Don't touch it,
Yeah.
because we'd be out of business. But still, I would imagine that down the road there have to be competitive, solid revenue cycle components, and I should be able to pick a different vendor for that particular business. You would imagine, I'm thinking down the road here, that you could do revenue cycle as a software as a service component, that I might not have to own that software myself or subscribe to it, that I could do this with multiple clients on multiple platforms. I see, for us to get away from this, buy everything from one box, start layering it so that I become more flexible on each layer. And the revenue cycle is, to me, like one future option to carve that out to a different company. Or there are less expensive versions of that. Well, fine, go with a less expensive version of a revenue cycle. It doesn't typically affect doctors and nurses. It affects billing. If you can find an effective billing system, why not go with that? Why keep that from your single vendor? So that's one idea, but I think this applies to other options also. Be more selective. But the key here is hospitals and health systems, who are the buyers, the consumers, need to be able to challenge that all-in pricing methodology and say, I am going to carve out a piece of my contract and go with a third party. It's hard.
Yeah. And speaking of contracts, I mean, Doc, I grew up in the 80s where everything was a contract. Your cable was a contract. Your phone was a contract. And then all of a sudden, I think a lot of businesses realize, oh, let's give our consumers freedom to jump around, and they'll be happy. They don't feel like beholden. You mentioned long-term contracts. What do these contracts usually run for? And I know we're speaking in broad terms, but tell me about the length of these contracts and why it's why it kind of locks you in for such an extended period of time.
Yeah, and a typical contract is 10 years.
Whoa!
And typical normal is 10 years. So that creates that also creates a lag time, right? That creates a very slow, and it sort of makes sense. It needs to be 10 years because it's difficult to switch a health system to an entirely different technology. So 10 years is also, I think, about the right time frame. One of the points I'm making, though, is you might not have to wait 10 years until you introduce new technologies. If my previous example, ambient documentation, or population health, value-based care, or any of the other examples, if you feel like as an organization, I want to move faster, I would recommend going with a third-party company on a short-term contract, 2 years, 3 years, and on top of the platform I have. And then after those 2-3 years, two things could have happened. Either it's fantastic. You're being more innovative, you're being faster, you're being more efficient. Awesome. Or after 3 years, your main vendor has caught up with technology and is now able to provide a competitive product at the same price point. In that case, you switch. The mindset that any tool I bring into my health system needs to be around for 10 years, I think, is also something we should be looking at. It should be okay for us to sign a contract for 2 years and reevaluate afterward. Health systems don't typically want to do that because it's a lot of work to introduce something and then 2 years later to reevaluate it. But I believe for us to be more flexible and innovative, that is another part of the mindset that we should be challenging and say, in some cases, go ahead, go with a 2-year contract or a 3-year contract on a third party and decide your next move once you're doing this. It makes you more innovative and faster to incorporate new technologies.
And it's funny, Doc, because one of the things that you talk about in the healthcare industry is how slow it is to adapt and innovate. And I think these large contracts or long-term contracts are part of the reason, because if you have a healthcare system and you want to change things and you were just hired, like there's 8 years left on this contract, the only thing you can do is add these short-term third parties, because
Yes.
there's nothing you can do to innovate, because you're stuck with this program that your predecessor may have signed
Yep.
before you got there.
So the challenge then is, if you do that, you're ending up spending beyond your base contract. So it is more expensive initially. Initially, it's more expensive. My expectation, though, is that if you were to do that and bring in third parties, that allows you to put you in a better negotiating position, that once you get to your 10 years, you can negotiate down. You need to put yourself in a better negotiating position for the next cycle of negotiations. So being fully dependent on your single vendor puts you in a pretty bad negotiating position. You could have to take whatever they offer. But if you have alternatives in place, currently in place, you could say, I'm not taking that. One of the people I interviewed for the book calls it an add delete schedule. So to have a specific schedule at the end of the contract that allows the buyer to add or delete specific modules. So that gets you away from the single vendor, single price mindset to say, let's at least have a schedule where I'm pre-pricing what I can either add or delete from my current technology. And it kind of opens the door away from the single price lock-in.
Nice. All right. So for hospital systems, healthcare companies that want to innovate, first step is buying your book. What's the second step? What's like a practical step? Like once someone has read the book, taken notes, they dog-eared it, all that stuff. What's the first practical thing they can do after reading Unvendor?
Yeah. So here's how I sometimes answer this question. If the vendor ever in your discussions, in your quarterly updates, in your tech reviews, if they ever use the word roadmap, that is a trigger word. Because roadmap means, so when the vendor says, oh, we have this on our roadmap, we have value-based care on our roadmap, we have home device interoperability on our roadmap, it means we don't have it today. It's on our roadmap. But it also means we don't want you to buy that from somebody else, because we will be getting there and we want you to wait until we get there. So if the vendor says roadmap, to me, that is a key trigger word that says, okay, good. While you're working on your roadmap, I'll go with a third party. That, to me, is the word that tells me, go with a third party, do a short-term contract with whichever technology you're looking for. And then if the roadmap ultimately gets you there, that's fine. In the meantime, you will have worked with new technology for several years and have gained experience and have benefited from the features and functions. So after reading my book, listen for the word roadmap. It'll come up, believe me, it'll always come up. And that will be your signal to say that would be an area we should be evaluating the market and looking at 2 or 3 innovative technology firms and bringing those into our organization. The second thing I'd say, invest, like I said it before, invest in interoperability. Create a team inside your organization that has the skill set and the knowledge, and also the mindset to become the working team to incorporate third-party technologies. I think that's the second investment. Today, hospitals are under a lot of financial pressures, and they are tending to trim down their IT staff, which is a shame, because I think the IT staff is actually their key to more efficiencies. I would say, rather than laying off your IT staff, build more IT staff in order to save money on your bottom line. I think that's the other message in the team here. So wait for the word roadmap, buy that technology from a third party, and invest in your IT team, in your IT interoperability team.
That's great. That's great. And lastly, so someone may have popped this on YouTube or listened to the podcast, and after 30 minutes, you're like, still not sold, Doc. I know you make some great points. I'm very hesitant about unvendoring. Do you have like a motivational pitch for someone who's just still on the fence after listening to all this, all the data you lay out in the book, and they're still hesitant? What words would you have for them?
First of all, they could be right. There is, I don't see this as completely black or white, as completely single vendor or completely diverse IT stack. You could make 1 move or 2 moves in the direction of unvendoring, where you maintain and retain most of your technology from a single vendor, but start incorporating 1 or 2 new technologies in innovative spaces where your main vendor doesn't work. That is an easy clinical, business, technical decision to make. Start there. So I think 1 or 2 steps in the right direction is better than no steps in the right direction. And I think a lot of this is mindset. I think it's organizational mindset, and that we need to break through. It's the vendors. We should not expect your big vendors to start doing this. No, they benefit from the current situation. So the latch is on the inside. Right here, we health IT consumers and my peers, CIOs, CMIOs, they are the ones who are going to have to make this first move. I would say do 1 or 2 or 3 steps in the right direction, or maybe even 1. Start with some obvious technologies that you bring outside. Ambient technologies is obvious one. There are some other obvious ones. And then I would say, look at the long horizon. I think what comes after the current phase, right? That we are currently obviously in a single vendor dominated space. I don't think it'll last forever. I think the next phase will be what I would call, and I mentioned in this book, as a platform situation where your single vendor forms a platform. But on top of that platform are many different technologies. That's not where we are today. Today, our system does everything in one box. Everything in one box. I believe we are migrating, and I think these vendors, the big 3 vendors, would say the same thing, that they want to become the platform. They are not today, but they want to go there. So I would say help your vendor become a platform vendor. Help your vendor transition from single vendor monolith into a platform situation where they handle core health business, but on top of that, they are the host, the platform, the base for many other technologies that are swappable. That would be my ideal future direction and my motivational speech for these people to say, move in that direction, because that's where the market wants to go.
Awesome. His name is Dr. Harm Scherpbier. The book, Unvendor, Innovative Healthcare with a Diverse IT Stack. Doc, thanks so much for your time. Really appreciate it.
Joe, it's a pleasure. Thank you very much.
And that'll do it for this episode. If you want to find out more information about Dr. Scherpbier and our other amazing authors, go to theauthoritycompany.com.